Hi, this is an introduction to the newborn musculoskeletal exam, screening for common injuries and deformities. My name is Casey Fine. I'm a fourth-year medical student at Boston University School of Medicine. This module was developed with the assistance of Dr. Gail March and Dr. Desmond Brown. The learning objectives for this module are that by the end of the introduction to the newborn musculoskeletal exam presentation, second, third, and fourth-year medical students will be able to do the following: identify common orthopedic injuries and deformities found on newborn screening exam, list the common risk factors for these injuries and deformities, outline a systematic approach to the newborn exam, summarize the first-line workup and management for each of the identified conditions, and describe or explain the concepts of management for newborn deformities, including early intervention, stretching, splinting, and casting. So the first question we might ask is, why is the newborn musculoskeletal exam important? First, the exam is important because it helps us screen for possible congenital defects. Some musculoskeletal exam findings are associated with congenital syndromes that impact other less apparent organ systems. By identifying these possible associations early, providers are able to perform investigation into the presence of these defects. Next, the exam allows us to identify common deformities and injuries in the newborn. While some deformities and injuries require no intervention, several of these are common findings, and they may improve significantly with early treatment. Finally, the musculoskeletal exam allows providers to document the presence of deformities that are common in normal pediatric growth, or injuries associated with birth. Documenting these allows providers to distinguish these pre-existing injuries or deformities from new injuries that may be seen on later presentation. This is helpful when a provider has suspicion of abuse or neglect. The first injury we'll discuss is the clavicle fracture, which is the most common birth-related injury. Now, how common is this injury? Some studies have shown that of recorded birth-related injuries, up to 95% involve the clavicle. When assessing for these injuries, it's important to note that 85% occur in the middle third of the bone, which is the most susceptible to injury. Most often, these fractures occur due to birth trauma, commonly due to difficulty in the shoulders passing through the birth canal. There are several risk factors for this injury, and all of them are related to making a delivery more difficult. When the child is an above average size or weight, or large for gestational age, they are more likely to sustain an injury. Children in breech presentation are also more likely to develop clavicle fractures. And finally, a prolonged labor increases the chances of clavicle injury. Now, how does a clavicle fracture present? Well, some severe cases of clavicle fracture may present with decreased or absent movement on the affected side limb. Most commonly, clavicle fracture presents with deformity or discoloration over the fracture site. This should be identified during the inspection portion of the exam. Less commonly, palpation may elicit pain or tenderness, and you may also be able to palpate crepitus, or an irregularity along the clavicle. And so this is during the palpation portion of the exam. So for every clavicle exam, you should first look at the child for any changes in movement or deformities, and then palpate each side independently, feeling for any tenderness or irregularity. While a newborn clavicle fracture can be identified clinically on exam, the diagnosis can be confirmed with an X-ray. Here we see a classic displaced fracture in the middle third of the clavicle. It's easy to imagine how the fracture shown here would be detected on physical exam, with localized swelling, possible visible deformity, or a palpable irregularity. Although this fracture is easy to see, the imaging findings may be less obvious in other cases. Now, how is a clavicle fracture managed? In almost all cases of newborn clavicle fracture, healing occurs spontaneously and no intervention is required. The most important component of management is identifying the injury and educating parents of the newborn to handle it with care to avoid worsening the injury. Overall, the goal is to minimize pain and discomfort. Some sources recommend immobilization if the newborn demonstrates increased fussiness or pain with movement. However, this intervention is often more challenging for the newborn and for parents, and is rarely used. If immobilization is desired, the arm is abducted more than 60 degrees and the elbow is flexed more than 90 degrees. As shown in the image, the arm can then be immobilized by wrapping it in a long shirt and pinning the cloth, as seen here. Analgesics are recommended in some texts as well. Follow-up with exam for callus formation and a lack of tenderness on exam is typically sufficient, and no imaging is required in follow-up. Next, we look at brachial plexus injuries. Now, the brachial plexus contains nerves that innervate the upper extremity. It runs from the cervical spine under the clavicle and through the axilla into the upper extremity. Injury can occur during delivery, either due to clavicle fracture or due to shoulder dystocia, where the shoulder of the newborn is stuck against the mother's pubic symphysis. This leads to stretching of the plexus, which causes damage that presents in an identifiable way on the newborn exam. And in fact, we can discern upper plexus injuries caused by the catching of the shoulder from lower plexus injuries, which may be caused by a stretching in the lower portion of the brachial plexus. Now, what do brachial plexus injury look like? The most common type of plexus injury is the upper plexus due to shoulder dystocia. Most cases you'll see are unilateral, and 85% of plexus injuries are upper plexus, involving the roots C5, C6, and C7. Presentation of C5 and C6 involvement typically appear with adduction and internal rotation of the upper arm, with extension of the forearm, but preserved wrist and hand movement. With C7 involvement, the patient will present with Erb's palsy, or waiter tip hand. This will look similar to the 5 and 6 palsy, but includes pronation of the forearm and wrist and hand flexion, which gives the full waiter's tip presentation, as if the child is asking for a tip. The lower plexus injury, C8 and T1, this is a lower arm paralysis with preserved upper arm movement, wrist and hand extension, which causes them to present with a claw hand. However, true isolated lower plexus palsy is very rare in newborns. It's almost never seen. More commonly, you will see a full plexus injury from C5 to T1, which may cause full arm paralysis. However, if the upper plexus begins to heal earlier than the lower plexus, you may see a presentation that is related to a Klumpke's palsy or a claw hand. So here we see some of the exam findings that you may anticipate on with a brachial plexus injury besides the positioning. Now you see here in the animation a normal Moro reflex. The baby is held up slightly, and then drop gently, eliciting a startle reflex, where the baby's arms come out to its side as if it's trying to catch itself from falling. However, a patient with a palsy may present with abnormal positioning or a unilaterally absent motor reflex, where you would see no arm movement in one of these arms, and that could be suggestive of a brachial plexus injury, given the proper clinical context. Now, how do we manage a brachial plexus injury? So the natural course of these injuries is not well defined. Most cases resolve in 1 to 3 months, but some number of cases may persist, with numbers ranging from 18 to 50%. However, the general management principle is that a brachial plexus injury, like other injuries, should be allowed time to heal naturally. If improvement is not observed with the first month following injury, physical therapy exercises may be used to help prevent contractures or atrophy. However, most often, spontaneous resolution is seen. So if observation does not sufficiently lead to the natural spontaneous resolution, physical therapy can include stretching or range of motion exercises. Splinting is rarely, if ever, required. Surgical management may be indicated if no improvement is seen after 3 to 9 months. And this is done using harvesting of a donor nerve and directly repairing the damaged nerve root. However, there is significant debate in the literature regarding the benefits versus risks of surgical repair. And as we said before, in most cases, these injuries will resolve on their own. Here, we see a video demonstrating the physical therapy stretches that may be used if improvement is not seen in the first few weeks. Here we see flexion and extension of the arm, followed by abduction and adduction at the shoulder. Next, internal and external rotation of the shoulder. This is followed by stretches of the elbow, flexion and extension with the forearm supinated, the palm facing upward. And finally, we end the stretching exercises with flexion and extension of the wrist and hands. These exercises should be performed at each diaper change, and the involved arm should be stretched to the point of resistance and held for about 20 seconds. Remember to move both arms equally. We continue the newborn musculoskeletal exam by moving farther down the extremities and examining the digits. And the next abnormality we look at is digit abnormalities, which can present as polydactyly, or extra digits, or syndactyly, which is the fusion of digits. And here we see a demonstration of extra digits, and here we can see fusion of the toes. Now, polydactyly, as stated before, describes the finding of a patient having extra fingers or toes. These extra digits may present as a spectrum from a very rudimentary extra digit to a fully developed extra digit with bone, nail, and muscles. This condition is often isolated and is almost never associated with systemic genetic abnormalities. Syndactyly describes the finding of the fusion of 2 or more fingers or toes. This condition may also present as a spectrum from a minimal amount of webbed connection between 2 digits to the full fusion of adjacent fingers or toes. And this presentation occasionally is associated with other congenital abnormalities, although it is rare. Now, what is the significance of the absence of digits? Well, we stated that polydactyly and syndactyly have rare or occasional association with genetic syndromes. The absence of digits is highly suggestive of systemic genetic abnormalities. In particular, the absence of a thumb is noted to be related to what is called the Vactral association. Now, Vactral is an acronym which describes the different systems that are impacted by this genetic abnormality. These include the following: vertebral anomalies, anal atresia, or the absence of an anus, cardiac defects, tracheoesophageal fistula and or esophageal atresia, renal or radial abnormalities, and here the radial abnormality is referring to the absence of a thumb, and finally limb defects, where we can see other more prominent limb defects besides the absence of a digit. How do we think about managing polydactyly and syndactyly? With extra digits, the first step is to assess for the extent of the extra digit attachment. You may see either minimal connection or a significant connection. With minimal connection, the digit can be removed either with suture ligation, which leads to auto-amputation, or more commonly now, the excision with a scalpel. This has become the mainstay of treatment for a minimally connected extra digit. If there's a significant connection with joint and well-developed muscles, we require operative removal. The patient would be taken to surgery. For syndactyly, surgical separation is performed in most cases, and often a skin graft is required for interdigital skin. Here we see some of the variety for how polydactyly may present. The image on the left shows a non-axial supernumerary digit. This refers to how the extra finger seems almost stuck onto the side of the hand, and while the extra digit itself may contain a bone, there is no significant attachment to the rest of the hand. It's connected merely by a band of soft tissue. This extra finger may be removed either by suture ligation or with scalpel excision. Suture ligation involves tightly knotting suture around the base of the extra digit, which restricts blood flow. This leads to necrosis, and the digit falls off on its own within about a week. However, complications have been found to be associated with this method, and the current first-line treatment for a minimally attached extra digit is removal with a scalpel. The image on the right shows an axial supernumerary digit. This term refers to an extra digit that clearly has significant involvement and attachment to the rest of the foot, as seen here. This type of polydactyly would be managed with surgery to safely remove the extra toe. This surgery may be performed as early as the child is deemed low risk for anesthesia. Often, these procedures are performed at the age of 3 to 4 months. Here, we see an example of syndactyly being repaired operatively. Here we see the back and palm side of the hand with significant syndactyly, and we see that the surgeon has drawn out the lines over which they're going to make their cuts to separate these digits. And here we see the same patient after separation. And as mentioned before, skin grafting is often used to help fill in the space in the interdigital space. The next exam finding we'll discuss is developmental dysplasia of the hip, or DDH. This refers to abnormality of the hip joint, either of the femoral head, shown here, or the acetabulum, where the femoral head sits, or a combination of both. The incidence of DDH in newborns is variable and depends on multiple factors, including ethnicity. In the US, the commonly cited incidence for DDH is that 1 in 1,000 neonates are born with a dislocated hip. And some children may present with subluxation, or a laxity of the joint, without full dislocation. However, as stated before, incidence varies significantly with ethnicity. At the low end of the spectrum, studies show incidence in African nations to be 0.06 per 1,000 live births. This ranges up to the high end of incidence in Native Americans, with studies showing as high as 76.1 per 1,000 live births. On average, 1 in 1,000 neonates are born with a dislocated hip. However, the incidence of dysplasia is higher, and there are degrees of severity of dysplasia, as seen in the images here. Hip subluxation is defined as displacement of the femoral head from a normal position. However, it is still in contact with a portion of the acetabulum. In contrast, in hip dislocation, there is no contact between the femoral head and the acetabulum. As described here, figure A shows a normal hip joint, with the femoral head seated well in the acetabulum. Figure B shows a dysplastic hip, with a shallow acetabulum, demonstrated here, but with the femoral head still in place. Figure C demonstrates joint subluxation, where the head is still in contact with the acetabulum, but it's not fully seated, as in the normal hip. And finally, figure D shows full dislocation, with the femoral head free of the joint. What are some risk factors for developmental dysplasia of the hip? There are 4 commonly described risk factors. They include gender, where female newborns are 2 to 3 times more likely to have DDH than males. Limited intrauterine mobility has been found to increase risk for DDH, and this could include things such as breech presentation, shown here, where the baby is bottom first as opposed to head first, or oligohydramnios, where there's limited amniotic fluid in utero, or being a firstborn child, where the uterus has not been as stretched as it will be in subsequent children. Family history of DDH is also a risk factor for future DDH in children. And swaddling, which is a particular way of wrapping a newborn, has also been shown to be associated with dysplasia of the hip. The next question is, how is DDH detected on exam? Well, the hip exam for the newborn is composed of inspection and provocative maneuvers, or maneuvers that the examiner will perform to try and elicit dislocation and reduction of the hip. Inspection involves comparing the skin folds at the hip on the left and right side. Asymmetry may be an indicator of hip pathology. However, this sign has very low specificity, and often asymmetric skin folds can present in a typical newborn without any hip pathology. The more diagnostic exam in the newborn are the Barlow and Ortolani maneuvers, which involve manipulating the newborn's hip joint to determine if dislocation is present or if the hip may be easily dislocated. The Barlow exam involves maneuvers intended to displace the femoral head out of the acetabulum in a hip joint that is dysplastic. On a positive test, the clinician will palpate the dislocation of the femoral head as they perform the following maneuver. First, the newborn's hip is adducted or brought to midline, drawing the knee inward. Next, the clinician will apply pressure posteriorly. If the newborn has joint laxity or hip dysplasia, the femoral head will be easily subluxed or dislocated from the joint, as seen here. However, this test has been shown to be somewhat subjective and not necessarily consistent from clinician to clinician. The following test, the Ortolani, is considered the gold standard exam for diagnosing hip dysplasia. In the Ortolani exam, the maneuver is intended to reduce a dislocated femoral head. It operates pretty much as the reverse of the Barlow exam. And on a positive test, the clinician will palpate the reduction of the femoral head as they perform the following maneuver, and this reduction is often described as a feeling of a clunk as the femoral head is reduced back into the joint. First, the newborn's hip is abducted, or the knee is drawn out towards the examining table. Next, the clinician will apply pressure anteriorly. If the hip is dislocated, the clinician should feel the femoral head reduce back into the joint with a clunk while palpating the hip out here. Once DDH is detected, how do we treat it? The mainstay of treatment is shown in the image here and is called the Pavlik harness. The goal of this treatment is to maintain reduction of the femoral head in the acetabulum. This is achieved by stabilizing the hip in flexion and abduction, as seen in the image. This treatment may be used from newborns up to 6 months of age. The recommended course of treatment is 6 weeks full-time in the harness, followed by 6 weeks part-time, allowing the child some time without the harness. This device has been shown to have incredible success rates, 95% of success for dysplasia and subluxation, and up to 80% success rate for full dislocation. However, even stabilization management is not without risks. Associations have been seen between positioning with hyperabduction and avascular necrosis, and hyperflexion with femoral nerve palsies. Follow-up at 3 weeks of treatment should show reduction by ultrasound of the hip. If improvement is not seen at that time, alternative treatments may be indicated. And here I've compiled some tips to remember when thinking about developmental dysplasia of the hip. First, each hip must be examined separately. This is very important since there is a temptation to examine both hips at the same time. Next, some clicking is a common and normal finding. Clunking is not. That sensation of a clunk is the palpation of the femoral head dislocating from the acetabulum, as in the Barlow, or reducing back into the acetabulum in the Ortolani. Now, this distinction can be difficult to discern and takes time and experience with this exam. And finally, for remembering the distinction between the Barlow and Ortolani, one trick is that B comes before O. So first you go out to the bar in the Barlow, and then you come home to Ortolani. We will continue our exam moving down the lower extremity to the lower leg and foot. The next deformity is talipes equinovarus, or clubfoot. Now, who gets clubfoot? The incidence is reported to be roughly 1 in 1,000 live births. Now, this condition is multifactorial, and the precise cause is not well understood. However, there are several risk factors that have been shown to be associated with clubfoot. A family history of clubfoot in one or both parents increases a child's risk. Abnormal embryological development of the talus, one of the bones in the midfoot, is also a risk factor. And this condition is seen most often in males more than females. Now, how do you identify clubfoot? Well, what does it look like? Here is a pretty standard presentation of a child with clubfoot. You see the forefoot is in fixed inversion and adduction. So it's rotated inward, and the forefoot is angled towards midline. In the hindfoot and heel, we also see inversion. In clubfoot, we may also see limited extension of the ankle and subtalar joint, and occasionally internal rotation of the leg. This combination of presentation is seen also with the fact that congenital clubfoot cannot be corrected by manipulation on exam. So this foot may not be manipulated to a normal position by the examiner. This is distinct from some other lower leg deformities which may be corrected. Early detection and treatment of clubfoot is crucial to avoid long-term deformities and deficits. The mainstay of treatment is serial casting, which has been shown to be highly effective in the majority of cases of clubfoot. Optimal treatment begins in the first week of life. The Ponseti method often requires 6 weeks of treatment and involves weekly manipulation and casting changes. After several weeks of casting, most cases involve a percutaneous heel cord tenotomy, or severing of the Achilles tendon, to complete the correction. After the surgical release of the Achilles tendon, there is a final casting for 3 weeks, and after casting treatment, the correction is maintained with nightly splinting with a foot abduction brace. And here we see the weekly casts as the foot is slowly brought from full deformity to normal positioning. Prior to the final cast being set, a tenotomy is performed. This procedure involves releasing the Achilles tendon with a scalpel, in a procedure that uses only local anesthetic. As shown in the image, the tendon sheath is identified, and the goal is to release the tendon without severing the sheath. This allows the final casting to occur with the foot fully dorsiflexed and allows the Achilles tendon to heal with enough length to allow for proper range of motion in the foot. Here we see examples of the foot abduction bracing. After the final cast is removed, the patient is expected to wear abduction braces for several weeks to maintain proper foot orientation. As you can see below, there are many different styles of these braces, with varying degrees of flexibility and cost. The final exam findings we will focus on are positional foot abnormalities. These are common findings that are seen as in-toeing or pigeon toes in newborns or young children. The most common positional foot abnormality seen in a newborn is called metatarsus adductus. There are other positional foot abnormalities that often don't present until later in a child's development, so we won't focus on those in this module. Now, what is metatarsus adductus? As I stated, this is the most common foot deformity in newborns, with an incidence of 1 to 2 per 1,000 live births. This is most common in firstborns, and it presents with a turning in of the forefoot, forming a C along the medial edge of the foot, seen here. Next, we need to assess the severity of the metatarsus adductus. This is assessed on exam, and this assessment helps us determine how we will manage this condition. So one way of identifying severity is determining how easily the foot is manipulated back to a neutral position. On mild, the foot can be overcorrected past neutral. With a moderate metatarsus adductus, the foot can only be corrected to a neutral position. And in severe cases, a very rigid foot cannot be abducted at all. Alternatively, severity can be assessed by drawing a line from the middle of the heel straight up the sole of the foot. In a normal foot, this straight line should come between the second and third toes. In mild, it's often seen in the middle of the third toe. In a moderate metatarsus adductus, seen between the third and fourth, and in severe, it may be seen between the fourth and fifth. Now, how do we treat metatarsus adductus? As stated, the severity determines the treatment. It's important to note that over 90% of all cases will resolve without any intervention. In particular, mild and even most moderate cases, no intervention is necessary. However, in some moderate cases, stretching exercises may be used, but only if deformity persists. In the most severe of cases, casting may be required. However, this is very rare and almost never indicated. This slide contains a review of the 6 exam findings discussed in this module. Here I've consolidated each of the conditions with the most likely cause or etiology, what exam is required to detect these injuries or deformities, and what the best first-line treatment is for managing these findings. You can review this slide on your own time. And finally, some key points to review the newborn musculoskeletal exam. Overall, I think the best way to think of this is examining the musculoskeletal system from the head down. First with inspection, looking at fingers for syndactyly or polydactyly, also looking at the spine for pigmented spots, hairy patches, or deep pits, and the legs and feet for symmetry, bowing, or torsion. Next, use palpation, both of the spine for lumbosacral vertebral deformities, and the clavicle for lumps, tenderness, or crepitus. Range of motion testing and flexibility is used on the legs and feet to detect hip dysplasia or correctable in-toeing. And some special tests that we discussed today were the Barlow and Ortolani exam